Hello, everyone. Well, we are back every single day educating on perimenopause, menopause, and beyond. Today, we have one of the leading voices in this segment of perimenopause and menopause in the world, for that matter. We have Vikram Sinai, who's joining me live from UK. He's one of the professors in women's health. He's dedicated his life to women's health. So thank you so much for your dedication to us, to the women all over the world. But today's
Thank you.
topic is really talking about all the controversial about the hormone replacement therapy, or what are the choices, what should women do? So without further ado, I'm going to have Vikram start the discussion. Thank you so much, Vikram.
Thank you. Thank you so much, Anita. And thank you for the opportunity to talk about menopause and HRT. It's a topic that's dear to my heart. Now, just a quick review or a sort of overview of menopause. We know that menopause is the hot topic right now, and that's because it's a stage of a life which may span almost 1/3 of a woman's overall lifespan. Many women will go through menopause somewhere around 45 to 50, and that's the average age of menopause across most countries. But there will be other women who might have early menopause between 40, 45, or premature menopause below 40. Some women will have surgical menopause. That's because of either a hysterectomy and removal of ovaries or other reasons like medically induced menopause for cancer treatment. The effects of menopause are far-reaching. And as there has been so much talk about it, it's important to recognize, one, there can be menopausal symptoms which can be unpleasant. And so people talk about hot flashes, night sweats, difficulty sleeping, vaginal dryness, bladder issues. Psychological impact can be profound. And this is something that was traditionally neglected as part of menopause talk. And then, of course, you've got the physical, psychological symptoms that then impact on your general long-term health. So the lack of hormones and the problems you're facing will affect your bones, your heart, how your brain functions, your cognitive functioning, and all those are the long-term effects of menopause. Now, how do we try and optimize a woman's quality of life in this situation? And some of the things I'll talk about will be very general because every individual woman's menopause will be different. And so we're not giving advice about individual women's experiences here, but it's about what choice do you have if you would like to address your symptoms, if you would like to maintain your long-term health. So if you look at symptoms, menopausal symptoms, usually about 80% of women will have some or other symptoms when they go through menopause, and about 1/3 of these women will have quite severe or significant symptoms. If you have symptoms, you can manage or try and reduce the unpleasant symptoms by doing a few things. It could simply be your lifestyle. And by lifestyle, that would include things like making sure you wear easy clothing, which reduces your hot flashes, multiple layers, for example, avoiding the synthetic clothes. Secondly, you've got diet, making sure you eat well. And this is the time when things will change in the body. So making sure you eat healthy, what often says is Mediterranean type of diets. Third thing will be trying to avoid foods which trigger your symptoms. For example, spicy foods or alcohol can trigger symptoms of menopause. So trying to minimize caffeine, for example, those will be the dietary aspect of trying to reduce symptoms. Exercise is really good. It helps with symptoms. It helps with psychological problems that can happen as part of hormones going down. It will help protect your bones and your heart and your brain, which is all the beneficial effects of exercise. Reducing stress, making sure you sleep well. So trying to avoid screens at night, for example, or making sure you have managed your work-life balance to give you enough 7 or 8 hours of sleep every night. Those sort of small things in the lifestyle, which will go a long way to help you try and minimize some of the unpleasant symptoms that can happen. So that's talking about the lifestyle. Then you've got some non-hormonal options. Non-hormonal options can be alternative therapies. So a lot of women may try herbal medicines, may try acupuncture. There's hypnotherapy, which has some evidence that it can reduce hot flashes. Then you've got non-pharmaceutical treatments, for example, CBT, cognitive behavioral therapy, or hypnotherapy, which can help with symptoms. And finally, you've got non-hormonal pharmaceutical treatments, and those will include things like gabapentin, clonidine, or other fluoxetine, sort of antidepressant category of medications. Now, these can help women if they would like to actively avoid taking hormones, or they have got some contraindication for taking hormones. And they will mainly help with mood, sleep, and sort of hot flushes, night sweat. But they may not necessarily give the benefits of the bone protection or heart protection, which can happen with hormones. And of course, all of these small sort of side effects can happen with antidepressants or other medication, like you can get dizziness. You may find that you have dry mouth, constipation, which is why the non-hormonal medications are not very popular when it comes to managing menopausal symptoms. So we looked at the lifestyle changes, we looked at the non-hormonal alternative or pharmaceutical treatments. The final one you've of course got is the hormone therapy. And over the last 10, 15 years, there have been so much controversy over the use of HRT in UK and also in the world. But things have become better, especially in the last few years, because what happened at the beginning of this century was that we had the publication of the two big studies, one from UK, the Million Women's, and the other from the US, the WHI. And people thought HRT for menopause was something dangerous. It would cause breast cancer, it would cause heart disease, it would cause stroke. A lot of negative publicity happened around the HRT at the time. But over the last 20 years, we've got more studies, we've got better research, we've reanalyzed some of the findings of those big studies. And we know now that if a woman chooses to have HRT because she's symptomatic at around 50 or 45 years of age, then actually for the next 10 or 15 years, she will have more benefits than the potential risks from taking hormones. So for majority of women now, we think HRT benefits outweigh risk. It will not only give a quality of life, but it will protect bones, prevent osteoporosis, will protect heart, prevent any heart disease later in life, or reduce risk. And those are really the benefits which need to be balanced against any small side effects or risks that can happen. And what are the risks that we balance that HRT against is, of course, for those who take oral HRT, there might be small increase in risk of blood clotting. So you try to avoid oral medications of HRT in women above 60, and a small increase in risk of breast cancer with a combined form of HRT. Again, when I say there's a small risk, it's an association. It's not that the hormones cause cancer, but there's a small association that if you use long-term HRT for 5 or 10 years with both hormones, estrogen and progesterone, there's a very, very tiny, something to the order of 1 to 5 in 1,000, tiny increased risk of breast cancer. And so you always balance the benefits versus risk. So women who come to the clinic will often choose based on how severe their symptoms are, what their medical history is, and they may choose to take HRT, or they may choose they will not take HRT and do the lifestyle and non-hormonal treatments. So that is in a nutshell where the menopause world is today. We've got much more awareness. There are lots of options, lifestyle, non-hormonal, hormonal, and a woman can decide with the help of her doctor what she would like to take. What we don't have is a universal access. That's the problem we're facing now, is that there's a lack of enough menopause clinics, lack of GP education, so that women can go and have access to all these options easily. And the battle for us in the coming few years will be to try and get primary care to get enough GPs and doctors trained in these options so that everyone can get easy access to care when they need about menopause. Any questions, anything that you want to ask me from here on, I'm more than happy to answer.
Sure. So I think you brought up a really good point. This is definitely has been very controversial as women. We get scared to the studies that had happened 15 years back, you commented on that had breast cancer, but then they found out the studies were not, they were invalid, right? So now the thing is, we have quite a few attendees. I'm going to open it up for any questions. But the thing is the lack of education, right? the lack of the information that can be misleading to an end consumer like myself, I'm included, is like you don't know what to do, right? That's that, and it's not only UK, it's all over the world for that matter. So that's my feedback, and then I want to open it up to everyone else if they have any questions or anything that they would want to bring out. You can unmute yourself or chat. You can unmute yourself, please. You can unmute yourself, and yeah, whoever wants to talk, please unmute yourself. Or put it in the chat window.
Hello.
Yes.
I do a bit of HRT. I used to do a bit of HRT, but I believe that the bottleneck is not the consultants, it's not the patients, it's the GPs. When we were medical students, we were brought up with the fact that this was a dangerous drug, and you just hope that it will never be your issue. But the more you've used it, the more we've realized that, no, it's so bad. And the more we've used it, we realize that we can pinpoint the bad part of HRT, progesterone, oral. And it's normal for progesterone to be the harmful part because progesterone makes the breast divide. That is what it does in pregnancy. During pregnancy, long amounts of progesterone, the breast divides. And it can become cancer because that division may not always go right. You remove oral progesterone or progesterones that get to the breast, you got a problem. When you look at estrogen alone now, it seems to protect against Alzheimer's, protect against memory, apart from the Alzheimer's, even COVID. Vikram will know about that. It seems to protect against everything, just estrogen. The moment you start using progesterone as oral or as a type that the breast sees, it just does what it does normally, which is to make the breast divide. So HRT must leave the literature. It must become ERT with Mirena, if you're going to call it HRT, because you're going to protect the womb. So the bottleneck is that we've been taught from when we were medical students, when we weren't really thinking about it, that HRT is harmful, and we still carry that problem. And if you can focus this sort of talk to GPs, in the area I used to live in, all the GPs knew about it. They just knew because I just never stopped talking about it. Estrogen is beneficial in all respects, except maybe oral estrogen, which can cause thrombosis, just like the pill. But what you really want to emphasize is we must forget that word HRT. And the worst we can get with it is ERT plus Mirena. That way you're protecting the womb, but the breast doesn't see the progesterone. Anyway, sorry for interrupting.
Thank you. Thank you. Thank you for your comments.
Should I block myself now again? Mute myself?
So I think you made a very good point there, is that, again, the differential action of hormones is something that we talk about. So you have estrogen, which will have certain benefits, certain risks in oral, in transdermal, in the route that you take. The progesterone, the main culprit for most of the problems associated with HRT, however small they are. And it's really important for someone to be able to access a professional, a healthcare professional who understands the difference, so that they can guide you about what exactly the HRT components are. What does estrogen do? What does progesterone do? What does the testosterone do? Do you actually need 1, 2, 3? How can you minimize the risk that comes from progesterone? Or how can you try and get the safest route of these hormones? And this is exactly what somebody who is experiencing symptoms should have access to. And hopefully with all the noise that's happening around, and if we stick to the evidence and the principles, we'll get there one day where every woman will have the right advice. But as rightly pointed, it's the primary care that I think we should be really empowering and educating all the time, putting all the resources there, so that the women get what they deserve.
I have a comment. I'm not an expert here, of course, but so the thing is, if you look at it, the perimenopause sometimes starts in mid-30s. When you look at data in some of the other countries, some of them are hitting menopause in the early 40s or even mid-40s for that matter. So my question is, the estrogen and progesterone, the hormone imbalance is starting to occur in mid-30s for women or late 30s. Do you recommend that some kind of an HRT be administered starting at that point, or they wait until the menopause is hit and then after that?
So I think it's important to take each individual differently and not to generalize rules, because although we know that there is a difference in cultures, so for example, if you're from Southeast Asia or other background, you might have menopause 5 years early, and you might have low ovarian reserve or hormonal changes, perimenopause, maybe happening in your early 40s or towards late 30s. That doesn't necessarily mean everyone will have a difficult time. So you might have a woman who is dropping her hormones, but her body is sensitive enough to use the little bit of estrogen effectively and may not have symptoms. Her bone density will be preserved until later in time when she's through the transition a little bit into an advanced phase. While others who are in a different way sensitive to the drop may drop their bone densities faster, may be more symptomatic even in late 30s, early 40s. And therefore, individualizing will be the key. It's not to offer HRT to everyone just because they think that they may be going through the early changes. It's important, therefore, for the health professional to find out, is this really early onset of perimenopause? What is the typicality of these symptoms? Would estrogen benefit in this case? Yes, then go ahead. But for others, you might find that there may be other reasons for their symptoms which are happening, may not be only perimenopause. So identifying the right person and individualizing based on that person's symptoms, medical history, ethnicity, I would go by that approach rather than generalizing it.
Got it. So any other questions from anyone else? Okay, someone asked a question here.
Can I ask another one?
Can you tell before who's more sensitive to estrogen? That's what someone has asked.
Everyone's sensitivity does differ. So there are women who will have still regular periods, a slight drop in the, say, a slight irregularity of periods and how much heavy they bleed, suggesting that their estrogen level is dropping down. And they may be very symptomatic right at that stage. Sometimes it's even difficult to say you're having regular periods, but actually you're symptomatic as good as somebody who would be completely without periods for more than a year. And there'll be other women at the other extreme who might have stopped periods for good. There's no more estrogen really being produced, but they may not be symptomatic. And again, that's the variation. Biology is always like that. You'll not have one size fits all. And so the bottom line is look at what you are going through rather than comparing yourself to what the other individual is going through, because everyone's sensitivity and what stage you get symptoms, what stage it affects your long-term health will be different.
Can I ask a question?
Sure.
Comment. I agree up to a point with that last statement. The reason I say that is that if I look at estrogens as estrogen for women, the long run for any human being is when you die. And estrogen, like Alzheimer's, is the largest cause of female deaths in this country. Alzheimer's, dementia. What happens in Alzheimer's? It's like your hypothalamus it's like currants, yes? If you put Cointreau in currants, it's very delicious. Well, the hypothalamus is where your memory is laid. And then it goes to the posterior brain. And the papers we've published on this matter, looking at different populations, looking at populations over time, show that estrogen protects the hypothalamus. But there's one but. It only works when you start it in the perimenopause. If you're 75 and you start estrogen, the hypothalamus is dried up then. So we've shown that perimenopausal estrogen is the one that helps prevent Alzheimer's massively. Now, we can say it's individualized to different people. A drug that you can't find any problems with, except if you use oral, where there's a small risk of thrombosis, which can prevent Alzheimer's, which can reduce your risk of dying. I mean, we're still getting cars, but if you can do those three things, especially Alzheimer's, But for Alzheimer's, it's got to be started in the perimenopause, not in the menopause. The evidence is, well, I do evidence a bit, and it's not just randomized control trial, it's all sorts of evidence, looking at it in different methods. Perimenopausal estrogen has an effect. When you take it in the menopause, it's perhaps too late at that time. Sorry to interrupt that.
Thank you for your comment again. Probably slightly differ because I want to see more evidence before I would say it certainly prevents Alzheimer's. But yes, there's a growing body of evidence that earlier you start the estrogen replacement, then yes, you could have some benefits for the Alzheimer's. So thank you for the comment. Thank you.
All right. So this
Anything else you want to ask me, Amita?
Yeah, no. I was just going to say this is supposed to be a very quick 10-minute session, which is turning out to be a quick conference here on estrogen and progesterone, which is great. You know, we love the interaction. So, you know, the thing is, I just want to comment, and you guys are expert here, is that women don't know that they should get themselves checked, right? When they're going through perimenopause. Like, for instance, if I'm having a baby, I know I need to go to a gynecologist. But women don't know that when they're entering this phase, they should go and consult a GP or a specialist such as yourself. Any comments and feedback? Because I honestly, we don't know what to do.
I think it's happening now. So we did a survey for the UCL to find out what women felt when they were in their 30s, 40s, past 40s, 50s. And it looked like for the past maybe couple of decades, there was a gap in sort of educating women as well as the GPs that maybe there should be a easy access for a woman who finds that she's going through the transition, just started having some menopausal symptoms, and then she could go to the healthcare professional and ask for advice, what her options are, what are the long-term effects of going through perimenopause into menopause. That did not happen for at least good 20 years. But as I said, positive aspect of things that are happening now, like the discussion we are having today, lots of other webinars, is that women are realizing, maybe I should see somebody, maybe I should talk to my GP, maybe I should talk to my nurse. So you can see that the kind of tide changing, the trend in a different way, that a woman who is now getting to 40s, late 30s, early 40s, 45, starting to notice period changes, this would be a good time to see your doctor and then actually talk through what will be the changes in the next 5-10 years. How can you optimize your lifestyle? Do you consider HRT? What would be the pros and cons? And then think about the next 30 years. How will you live the best of your life, both in terms of quality and physical aspects? That seems to be starting to happen. There's a long way to go, but that's the aim for the next 10 years.
All right. Well, thank you. Comment, great session. Thank you so much. Would love to attend another session on various estrogen progesterone formulations. Any other comment, any other feedback before we wrap up? Like I said, this is a quick, I know Vikram Sinai is very busy. I know all of you are very busy. Any other last comments before we wrap up?
Thank you, everyone who came and gave us your time. Thank you, Mr. Onwude, and everyone who commented. Thank you so much.
Thank you. Thank you so much. All I have to say is that's what we are trying to do, is bring awareness of this whole process in women, perimenopause, and also educating them not only about the natural alternatives, but also, you know, the other alternatives that women need to do, but really start this journey in, and self-inspection of your journey when you are in your 40s or even earlier. With that, thank you so much. Thank you so much for your time. I really appreciate that. And thank you for your comments. I really appreciate that.
Thank you, Amita.
Thank you.
Thank you. Bye-bye.